Thank you. Those were beautiful cases. It really is an art. It is not so simple to do these. I'm just amazed at all of you who do it every day. So I'm going to talk about calcification, and I think there are mainly three types of calcification we know, and that is the atherosclerotic fibrotic calcification. You got medial wall calcification, we talked about it, and infantile calcification, and I won't talk about infantile calcification. So here's to show in the coronary arteries, you can see in plaque rupture, you seem to have less at the site. There is less calcification as compared to fibrocalcific plaque in patients who have stable angina. They've got diffuse disease, as shown here, and corresponding histology to show that the amount of calcification is quite extensive, as shown here. Whereas in the case of site of plaque rupture, as you can see here, the calcium is not as much. Here's calcification of the popliteal artery. You can see again, this is all intimal calcification. You can see the amount of narrowing quite clearly. You can see here, and you can see that there's severely narrowed, and there's calcium. The purple areas representing calcium, or the black areas representing calcium. So what about Monkeyberg's calcification, which occurs in the arterial wall? That is, here's the intima, here's the media, you can see all the way, internal elastic, external elastic, and you see the calcium in black. You can see the same thing in, if you do an H&E stain, you see it in purple, and you can also see sometimes bone formation within that, and this is by OCT. In the same arteries, you can see the calcium discrete, low area. You can see here discrete area of low intensity. So if you look at coronary calcification, we know that 46% of individuals who are dying suddenly, less than 40 years, will show calcification. 79% men and women aged 50 to 60 years, and 100% of those aged greater than 60% who are dying suddenly. There's a 10-year lag in coronary calcification in women until the extent of calcification equalizes in the 8th decade. Of course, the risk factors are well known. You know, diabetes and renal failure are the two most important. And of course, vitamin D levels and genetics also play a very important role. What we did in this is we looked at calcification of coronary arteries on the radiographs of these hearts, and we divided it into less than 5%, as shown here in A here, and you can see 5 to 10% calcification versus greater than 20% calcification of those arteries, the coronary arteries. And what we show here is when you look at the distribution less than 40 years, 40 to 49 years, 50 to 59, and you can see greater than 60 years, you can see that the amount of calcification, as shown here, the light pink decreases, whereas the darkest, the greatest amount of calcification, increases with each decade. What about calcification of the peripheral arteries? You can see here we've done, this is in a patient who did not have coronary disease, peripheral vascular disease, but we got the leg, and you can do this CT on this particular. We did angiogram, as well as we took the artery off and then looked at the extent of calcification, and again showing severe calcification, as you can see here on the right. Monkeyberg's calcification in asymptomatic individuals in the femoral popliteal region, we looked at these arteries and said, how many of them have? This is asymptomatic individuals. You can see good 50% of them have anywhere from 1 quadrant to all the way 4 quadrant calcification. So these are asymptomatic individuals. So quite extensive presence of medial calcification in the peripheral arteries. This is looking at 58 patients who had diabetes, who had amputation, lower extremity in the case of 57%, below the knee, and then above the knee in 43%. And these patients, over the 2-year period, had this. And you can see 50% had extensive non-ulcerated, non-healing ulcerations, and 71% had gangrene. So what was the extent of calcification in these individuals? What you can see here is you can look at the luminal narrowing. 50% of vessels show severe calcification. But if you look at, on the other hand, you look at medial calcification, again, 50% show greater than 50% circumferential involvement by medial calcification. So the presence of medial calcification and concomitant atherosclerosis was observed in 77% of the total segments. However, the extent of atherosclerosis did not correlate with the extent of medial calcification. Looking at the same data, looking at femoral, popliteal, anterior tibial, posterior tibial, peroneal, and dorsalis pedis, you can see that atherosclerosis is greater percent narrowing, and if you look at the extent of medial calcification, sort of tracks, but it is much more so below the knee as compared to above the knee. And you can see here circumferential femoral calcification in the case of medial calcification. And you can see that in the lumen, there isn't that much luminal narrowing, and this is from a patient who had amputation. So just to show you medial calcification and intimal calcification, this frothy-looking appearance, this is classic of medial calcification on radiographs, whereas atherosclerotic, you see dense calcification. As shown here, you can see this is medial calcification quite clearly. This we've done exact, this is after embedding them in elastic and plastic, and you can see the calcium is black in this case. Whereas where there is intimal calcification, you can see in the intima, as shown here again, showing intimal calcification atherosclerosis, it is within the intima, media is spared. This is to show you in the popliteal, a plaque rupture, you can see here, and you can see very clearly the intimal calcification, as shown here, it's dense calcification in the case of intimal calcification, whereas in the case of medial calcification, appears much more frothy looking. So if you look at the plaque distribution overall, if you look at fibrocalcific plaques, this is in the femoral, you can see large amount of, but if you look at fibrocalcific plaque, nearly 40 to 50% will show you fibrocalcific plaque. Whereas if you look at, in the case of popliteal, we see even more calcification. And of course, CTO is greater here. We see it in the femoral, not so much. Mind you, these are arteries that we got from patients who were asymptomatic. And it is amazing the amount of disease that exists. Could we go further? So here what we did was we looked at vascular calcification in human peripheral arteries. You can see the peripheral arteries, femoral-popliteal here, showing the below the knee arteries here very clearly. What we did, we asked the question, what type of calcification is there in these segments? We looked for microcalcification, fragmented calcification, sheets of calcium and nodular calcification, intimal and medial, and also looked for bone formation. So this is what we call microcalcification, which you cannot see by any of the means today, but we can see by histology. This is fragment calcification, just one spot you can see. Sheets of calcium, you can see the extent of calcium extends at least a quarter of the distance and around the circumference. And you can see nodular calcification. This is broken up pieces into multiple pieces. The calcium is broken up. So looking at the distribution of the calcium in the popliteal, here is in the femoral popliteal overall. But if you look at in the femoral artery versus that in the popliteal artery, you can see sheets of calcium are much greater in the femoral as compared to the popliteal. And of course, fragmented calcium is much more in the popliteal as compared to the femoral. And then you can also see nodular calcium, 2%. So here's location of calcium and bone formation. You can see here no calcification. Overall, there is intimal calcification seen in green, medial calcification in red, and intimal and medial calcification. Good quarter of the arteries will show you intimal and medial. Pure medial is unusual. And then if you look at bone formation overall, bone formation was seen in 12%. And this is in femoral much more as compared to the popliteal artery. So looking at distribution below the knee, again, you can see tibio-peroneal, looking at, in the case of anterior tibial, posterior tibial, and peroneal. You can see overall that we see actually more calcification in the case of tibioperoneal and the anterior tibial as compared to posterior tibial or the peroneal arteries, the fibrocalcific plaque. This is to show peripheral artery disease below the knee. You can see total occlusion here. This is by CT, this is by angio, this is histology. You can see this is a long total occlusion. And these are negatively remodeled and difficult to open. I believe these are very tough to treat. Here's medial calcification of dorsalis pedis artery, just to show you by CT. Look how it looks, circumferential, very clearly in the media. The intima is spared. And overall, I'd like to just summarize that calcification is not unusual. It's greater in the below the knee as compared to above the knee, but I think we have to be careful about medial calcification, which is the more important. Thank you so much.